A cordial welcome from Europe and the US. We are in a difficult time now, and unfortunately we cannot meet in person, but we prepared hopefully a very interesting webinar, and thanks to Teleon and LENSAR who really supported this. I would like to first introduce my co-moderator, who is Robert Weinstock from Tampa in Florida. He is a great innovator. He is an excellent teacher and educator, as well as he loves technology. And of course, he is a very good surgeon. And he has a long track with the LENSAR system from the very beginning to the latest innovations. So welcome, Robert.
Thank you, Burkhard. Pleasure to be here with you, of course. It's a great honor. And first time, I think, during this whole coronavirus pandemic that I've had an opportunity to do have a global feel. So this is fun. And I look forward to talking to my colleagues and with my colleagues from around the world and have a nice interactive session with you, Burkhard, and share some pearls and find out what we're doing similar and different and how we're using this amazing technology together. And we don't have to wear masks today for this because I can't spread the germs to any of you, fortunately, through a computer. So wonderful. So we're gonna jump right in then, I guess. We got the next slide, please. We'll take a look here, and Burkhard and I will take you through some information. And just a quick look at the agenda. We're going to try to stay on. We have up to an hour and a half. We'd love for you all to give us some questions, and Burkhard and I are happy to answer any questions that you may have or any comments or discuss things. We're going to talk about the LENSAR system, iris registration guided astigmatism. Burkhard has some amazing complex cases to show us. We'd like to talk about workflow in the laser room. We'd like to talk about our practices and how we're using this to be successful. Next slide, please. So I think I'd like to first start, and some of you may know that as this and some may not, but LENSAR has a pretty amazing track record of innovation. And, you know, it's no surprise because it's a small, nimble company. And we know that smaller, innovative companies have the ability to mature their technology faster than, say, bigger companies. And that's why we see a lot of the best technology in ophthalmology and in other specialties start in the hands of smaller companies and then get acquired by bigger companies where typically it stagnates. But we are fortunate in that we still have a nimble, amazingly talented group of engineers and sales and support team and clinical operations people led by an amazing leader named Nick Curtis. Maybe many of you know him or met him. And Nick has done a phenomenal job of pushing this team to continue innovating. I started with this technology very early on when I had one of the earliest units. And at that time, I was already using the LensX unit and the Victus device as well. So I'd already had quite a bit of experience with femtosecond lasers. And Nick and I have a very good friendship. He came to me and he wanted to compare the units and see the pros and cons and how it stacked up against the devices. And right away, I was enamored and fell in love with this device. And a lot of it came around the innovation that it has in the imaging space and the shine through camera. And this is just a slide that just shows all the different things that have happened all the way up from the last 10 years with innovations in software, leading to the current modality where we now most recently have this refractive capsulotomy and iris registration that continues to, as Burkhard and I will go into, dramatically affect our refractive cataract surgery. Next slide. So Burkhard's going to take us through some of the in-depth features of the imaging system that really distinguish this device from the other devices on the market and why we prefer this in our setting for our refractive cataract patients. Burkhard?
Thank you, Robert. And I would kindly ask all the colleagues around in our webinar that they use the question box there so that we can interactively answer to any issues or questions you have, please. Next. So my talk is about augmented reality and what does that mean. And well, as you can see here, you see the head of the system, the LENSAR, incorporates, as Robert already told, a Scheimpflug camera, and the camera performs more than 10 shots, so in different angles. And these information then is more or less remodeled as a 3D version, and can then exactly seen, and the information is provided on all important anatomical aspects. Next, please. So what happens is that we have an overlay, and this overlay exactly tells you about the dimensions, and based on the biometric data and the optical ray tracing technology, it provides you all the information, the very valuable information of Scheimpflug. And LENSAR is the only platform, to my knowledge, that uses Scheimpflug technology because it offers several advantages over the OCT technology. And so based on this 3D presentation, we can conduct a custom treatment planning. And that is what you see on the right side, and we will address this later on, please. So what we want is a perfect round-sized centered capsulotomy with good edge quality that is stretchable and guarantees a 360-degree overlap, as we all know, especially in premium IOLs like light adjustable lens technology, multifocals, enhanced depth of focal IOLs, as well as toric lenses. It's mandatory that we have no movement of the lens later on, which is of course more guaranteed if there is a 360-degree overlap of the capsule on the optic. Next. So with the system, we can more or less guarantee this. And what is often forgotten in this context, because many surgeons claim, oh, I'm doing a perfect capsulorhexis already, is the fact that if the very rare but not absolutely uncommon event that there is a posterior capsule rupture occurs, you will be very happy if you have a perfectly sized, perfectly centered capsulotomy, and which is not too big and which is exactly where you want it, so that you can implant the IOL into the sulcus or wherever you want and fixate it to this capsulotomy, which gives you a perfect, centered, long-lasting situation. And that is some kind of guarantee that you also provide with the system, which nobody mentions because this is more or less a taboo topic, of course. Next, please. So what we are talking about is the hope that we can guarantee 360-degree. And how is it done? It is done because the system is so clever because of the 3D modeling of the true anatomy of the current status of the eye that it detects the head position, natural lens decentration or tilt in 3D again. So what I personally am using and recommending is a centration of the natural lens, because not all systems on the market can do this. Most of them offer a limbus or pupil centration rather than the detected capsule formation of the anterior as well as the posterior capsule and the equator calculated. And this allows us to adopt the capsulotomy diameter for the individual choice of the IOL. Next, please. So what we did is what you can see here is one case with the system Robert already mentioned, that this was the LENSAR system from Alcon. And this is a case of mine where I thought I was perfectly centered, but if you look exactly and stop a second, you see that it's a classical inhomogeneous dilation of the pupil. And with a broader pupil inferiorly, which is superiorly in the reality, in the screen, and superiorly, you see it's wider. So what that means next is that you have a decentered capsulotomy, which you definitely do not want in these premium patients, because they expect perfect, not only round and dimensioned capsulotomy, but also centered. And this is, of course, then decentered. And this is something where a multifocal lens may decenter in the postoperative follow-up. Next. So what we did is a prospective randomized trial. Next. That allows us centration of the lens into the capsule. As you have seen, the lens models, they are negative dysphotopsia lenses, for example, and the back in the lens, of course, perfect lenses for this technology. But in order to achieve this, with these modalities that are available in Europe and are used already in clinical trials and in normal reality, is that we have to be aware that the centration method is not so important. Important is that your choice of the IOL. Most of us will implant a one-piece IOL, and there is my recommendation that you choose and go for a capsulotomy diameter of 4.9, because we found that once you go over, you have a slight but increasing tendency that the capsulotomy will not be a 360-degree on. With 4.9, you're always in. For a three-piece IOL, which is rarely used, of course, a little bit smaller, 4.7, and a plate haptic IOL is more forgiving, it's 5.1. Once you go over 5.1, you need to be clearly aware that you're really starting and getting too wide capsulotomies. So what I want to say is there is no single ideal capsulotomy size. That is an individual question. And this is more or less determined not on your centration, but the lens you intend to implant. Next, please. And also what is based on augmented reality and what I really like is, because Scheinflug technology, in contrast to OCT, is capable of detecting the hardness of the lens and the configuration of the lens cloudiness and what you expect in terms of how hard it will be to operate on this eye, especially in lens evacuation. And by identifying the nuclear morphology and the density within the cataract, which is automatically done, you can preset your fragmentation pattern, which you would like in terms of cuts, etc., quadrants or sextants, hextants, or whatever you want. And so it definitely optimizes your lasing time, and of course, tremendously, as we have shown in several clinical trials, tremendously reduces your ultrasound load to a minimum, if not elimination, of ultrasound. Next, please. Also, Scheinflug-based allows us individual adjustment fragmentation. And Robert, you wanted to just tell you this case, what it helped, how it helped you.
Yeah, sure. First, before we show that, I want to reiterate what you said, Burkhard, the ability of the capsulotomy and what a critical part of the procedure it is. And I know that that's always a hot topic with femtosecond laser surgery. And I think you and I both agree that the more we automate and reproduce the same thing every time in cataract surgery, it would only naturally lead to a more reproducible result. And until we have lenses available routinely that you can adjust after surgery, which we know is not quite there yet, even though we have one adjustable lens on the market at the moment, right now, all of us, we put a lens in the eye and we're stuck with that. We don't want to have to go back in there. And the ability to have the lens stay where you put it, not just in the short term, but in the long term, and not tilt or not prolapse forward, and not to have irregular contractile forces on the capsule that then moves the lens and decenters it. This is a critical part to long-term success for the patient. And the ability of this system to be able to choose between either setting the capsulotomy on the pupil, which you have to do sometimes if it's a small pupil, but if the pupil dilates large enough, I think the wise thing to do is center it on the optical axis, which is the closest we can to centering the capsulotomy on the center of the capsular bag, because we know the lens is going to sit in the center of the capsule bag on most cases, and therefore you have this symmetric overlap. And it's not just for complex cases, it's for the routine refractive and non-refractive cataract surgeries to try to make sure that that lens stays in one place and to have better long-term refractive stability for our patients. And what you just mentioned about the Scheimpflug imaging, Burkhard, with the automatic density nucleus grading, OCT can't pick up on the subtleties of the density of the nucleus. And for us to be able to grade these cataracts, we don't even have to grade the cataracts anymore. The laser grades the cataracts with the Scheimpflug imaging. So you can customize a pattern, whatever you want that to be. And I don't know about you, but I find that most of the cataracts, there's very little hydrodissection and hydrodelineation once they've been treated by femtosecond laser. And I think it's another subtle point about fragmentation that's missed, is that I don't struggle to rotate and spin the nucleus with hydrodissection, which, by the way, in certain cases, just that maneuver can damage zonules by trying to spin the lens if it's stuck. There's a pneumodissection that happens when you have these custom fragmentation patterns where the air release and the gas release from the femtosecond laser does a self almost hydrodissection of the lens. So I don't know, Burkhard, do you find that the lens
Yes, I fully agree with
you. They would normally, that if you didn't fragmentation?
Absolutely, I fully agree with you.
So I think there's all these little subtle features. Go ahead. Is it help you feel safer about nucleus removal, less ultrasonic energy, all of these little subtle features that help with fragmentation?
Absolutely.
Let's have the next slide, please. And bring that back up for us, Lauren. So, great points. Now, with this particular case, it's just a nice, I'll tell you when to play in a second here. Go back one to that video. Yeah, let's play that, Lauren. Thank you. So this is just an example of kind of how the software works. And you can see how quickly the imaging takes place in the processing and the reconstruction of the image. It's a little bit of a smaller pupil, but we're talking here about the fragmentation pattern of how it can customize it in the denser parts of the nucleus right there. And we're going to be doing a customized capsulotomy for a toric lens in this case. And we're going to go into that in a little more detail shortly. But this is a case that I needed to see decentration on the pupil because it was a small pupil. So you're really in a customized situation case by case when you decide where you want that capsulotomy centered and your fragmentation pattern based on how much density is. In this particular patient, the Scheimpflug categorized it as a category 2, which for me is 4 cuts and several rings of a fragmentation pattern. Once it goes up to a category 3 density, I start to use more robust fragmentation patterns with cubes, as well as cuts as well radially. Next slide, please. So this slide is also talking about the next application of the femtosecond laser, which is the incisions. Now, I'm not using on any of my femtosecond platforms that I've used. I've typically stayed away from making my primary and secondary corneal incisions because it gets too close to the arcus and the cuts are incomplete. So I still feel like a diamond is a little quicker and more reproducible and just easier to get open, obviously, than the laser. But for low amounts of astigmatism, I use this laser all the time with iris registration for creating arcuate incisions on the cornea for correcting 1 diopter and under. Now, in the US, we don't have the myriad of toric powers that many of our European and global colleagues have. So we tend to, since we don't have low power torics, I have a lot of patients with, most of my patients, half a diopter, 3/4 of a diopter, 1 diopter. I will make arcuate incisions based on iris registration factors, which we'll talk about in a few minutes, that we use for correcting local low amounts of astigmatism. And the laser will re-image the eye after fragmentation and capsulotomy immediately before the incisions are placed to make sure we have the precise location and depth localized in that particular area of the cornea. The other systems do not do this. We know that one side of the cornea may be a little thicker or thinner, and to get accurate reproducible results, we want, a 90% depth, but that has to be localized measurements. And that's what this system does very nicely. Next slide. Okay, so we have our next session. We're going to be talking a little about iris registration, and this really gets into the heart of the refractive capabilities of this laser. Next slide. What I think is important to understand about refractive cataract surgery, especially with astigmatism correction, and we all kind of know this, is that unless you put a toric lens or an arcuate incision at the right axis, you're going to run the risk of having inaccuracies postoperatively. And we know that there's a myriad of ways of marking an eye, but this far and away for me is the most efficient, most effective, and most precise way of using a toric IOL. This system has the capability of wirelessly connecting to the Pentacam, the Aladdin, the Cassini, and the NIDEC OPD, all preoperative corneal astigmatism devices, measurement devices. All of these images take an infrared photo of the eye, as well as Ks and other features of the cornea. It's that infrared image that is then fed wirelessly to the LENSAR laser prior to surgery and is uploaded. So when the eye is docked under the laser and the patient is docked, once the eye is docked, the infrared camera of the LENSAR laser marries up the preoperative infrared undilated image, and using proprietary registration software compares the undilated to the dilated pupil and compares similarities to the iris features that then does an immediate cyclo-rotation correction. And then, as you see on the bottom right of the screen, that's what the capsulotomy now looks like in my toric cases. And this software is taking off amazingly through the US, and all the LENSAR surgeons are now using this refractive capsulotomy for toric IOL alignment. Most of us have abandoned NORA. Most of us have abandoned preoperative marketing. Most of us have abandoned intraoperative maneuvers inside the OR with the microscope, like Zeiss's Callisto or TrueVision's 3D guidance system. We're not using that. We're doing it all with the laser. Next slide, please. So when we first software, and we had the ability to measure cyclotorsion at the time of cataract surgery, we did a study. We measured all the eyes that came in for cataract surgery, and we just took a quick sampling of patients, and we showed that on average, the average cyclorotation that happens to anybody's eye when they lay down on a table is 7 degrees, plus or minus 5. We saw a range somewhere up to 20 to 25 degrees of cyclorotation. Even when you bring the patient straight in under the laser and you try to get the patient perfectly perpendicular to the laser, there's still a tremendous amount of cyclorotation. Next slide. In fact, this was good information to see, but our data showed that the cyclorotation actually was in cyclorotation of the eyes, and that must have something to do with brain function or something to do with some type of body posturing position when someone lays down. But it typically seems like most patients in cyclorotate their eyes when you lay them down. Next slide. So that then speaks to how do we get the toric IOL in the right position? Well, on the left side of your screen, you can see the graphical overlay of what the capsulotomy is going to look like. Now, you notice that capsulotomy is not centered on the pupil. Why? Because we've chosen to center the capsulotomy, like Professor Dick mentioned, on the optical axis, because we want that capsulotomy in the center of the bag, because we know the lens is going to sit right there. And using the preoperative Cassini, which is one of the devices we use, we imported the image and we set up a situation for a toric patient where the capsulotomy was going to be shaped like that, with those little marks or nubs in place as a guide. And on the right side of your screen, you can subtly see with a good red reflex that little tab or nub on the capsulotomy, and then underneath that, even though it's on 3D, you can tell what's happening here. You have the marks of the toric IOL. Now, The first generation of software that LENSAR had with this was to have corneal marks with iris registration. But with corneal marks, the cornea is way above the IOL. So if the eye is tilted or the head is tilted, you get parallax. And that makes it a little harder to line it up. This mark on the capsulotomy is pretty much in the plane of the IOL. So it doesn't matter if the patient is belling up, looking left, right, or the head is tilted. It's much easier to align the IOL with the mark on the capsulotomy. Next slide. Play that video for us here real quick. So there's the undilated photo that was imported right there you saw from the Cassini, and that's in the system already. Be amazed how fast this happens. This usually happens before you even come in the room. They're just putting in the parameters for the patient. Now the patient is docked. Now we have imaging. You look on the shine fluid, not a very dense cataract. There's the two iris strips, and there was the alignment. This patient, 11 degrees of cyclorotation. That could cause up to 25% reduction in the correction of astigmatism, depending on the toric IOL that was being used. And that could be quite a bit. So if that was a T9, you could have over a diopter of miscorrection if you weren't aligned properly. And then this is afterwards, just a little live video in surgery. You can see that I've aligned the toric IOL right on that little nub. I know a lot of people probably are thinking to themselves, well, is that going to tear right there? Is that a weaker capsulotomy? There have been extensive studies done on the bench of stretching these capsules by mechanical devices and then translating clinically. We are not seeing that there's any weakness because of the curvature of it's not like a very sharp edge, it's a nice little curve right there. And the tensile strength there is just as strong as any other part of the capsulotomy, not only from on the bench, but it's what we've noticed clinically. So the rate of anterior capsular tear is no greater there than would be noticed during a manual capsulotomy or a round laser created capsulotomy. And my clinical experience, it says the same. Next slide, please. Okay. So this is just a summary of some studies. Some of our colleagues around the globe, Dr. Visco, Dr. Rebenich, Dr. Stevenson, have all done studies with this software showing as good, if not better, reduction in cylinder for patients who are undergoing toric IOLs with this software as compared to Aura, compared to manual marking. And the scattergram on the bottom right, you can see how tight it gets post-treatment. You can see how well astigmatism results go down and how little residual astigmatism there is in the patients that and in the surgeons that have access to this technology. Next slide. Just as a summary of some of these things we've been talking about. Using the latest diagnostic equipment and IOL technology, like Burkhard mentioned, really helps what we do. And using the right toric IOL calculators, the right nomograms, using a laser such as this to do iris registration and toric IOL alignment with the refractive capsulotomy. These are all part of the whole sense of tools that we're using together to achieve good refractive results on our astigmatic patients. And then obviously you have to collect your outcomes, and you have to do your own assessment of your outcomes and make adjustments along the way. Anything to add, Burkhard, about toric IOLs and the use of femtosecond lasers and your experience with some of this technology?
So I fully agree with all you have said, but I would like to again really point out that the IntelliAxis system is so strong. Yeah, it is not only measuring all the time, because we had only one case where the preoperative assessment was, in terms of the quality, not that good as we expected. And then nothing has happened. You just go back and can really mark the target axis or whatever and adjust it with the laser. But in all other cases, we used IntelliAxis, and these are hundreds so far. It worked, and it is, as you said, in the axis, so that you can exactly align the dots of the torus to these knobs. And compared to data injection like Callisto or something like that, there's always a displacement and all these things that movement of the eye or not correctly centered, etc. So I can really say that we are very happy with the IntelliAxis, which is by far the only system and technology that's currently available on the market that offers this this great tool. As you mentioned, it's a clear advantage in terms of clinical performance for our patients.
Totally agree. You know, I've worked with all sorts of intraoperative technologies that once you've taken the cataract out, you put the lens in, and you're spending sometimes more time than you did taking the cataract out just trying to get the toric, whether it's a blue mark on the pen or some reticle that you place on the eye, or even an automated device like Aura, where you're chasing the numbers and moving it one way, then the other way based on the Aura readings, or Callisto waiting for the overlay, and there's a delay on it. Even the Varion system that's superimposed through the microscope. All of these things take a lot of time in the operating room. The cornea can be dried out. The chamber could be collapsed. There could be viscoelastic under the eye. I mean, the variables are overwhelming at that point in the procedure. So I've fallen back to trusting a good preoperative measurement of astigmatism axis and magnitude, a good device like LENSAR that is going to give me a good mark of where I need to be, taking into account my SIA, and then putting it there and leaving it there. And I've been extremely pleased with the results. So I couldn't agree more with you on what you said there. Well, let's keep moving. This has been good, and please have any questions.
Insurance company in Europe will ask for that in the future, because you are 100% sure you're treating the correct eye of the correct patient. Yeah, and it's not changed by chemosis or something like that. With the Callisto, we had several cases where we weren't able to didn't detect. So that means you have to detect beforehand, and then into this procedure recognize it's not detecting any longer, which is a disaster, because then you cannot mark or something like that. What does that mean clinically? You're marking once you're using the Callisto only. What we don't do at all with the IntelliAxis.
Yeah, it's a huge time saving that everything's already done by the time you get in the operating room and process. Well, why don't you take us through some of the more unusual cases and different applications that the laser is applicable for?
Yes, we are using the LENSAR for an all-comers approach, which I think is important, so that we don't have to select this patient cannot be operated or has to be operated with another system or whatever. So really it's used for every patient. And that means also, of course, we are talking about more complex eyes. Next slide, please. And not the normal, slightly cataractous eye, but based on my personal experience, which started in 2011 with about 800 to 1,000 femto procedures per year, and based on all the peer-reviewed literature, I would say the LCS, the laser cataract surgery, is extremely valuable and important and good for patients and eyes with compromised endothelium, because you're decreasing ultrasound. For eyes with a shallow anterior chamber, because it's not so it's done, everything is done already, and especially also in dense and very hard cataracts, where the lens is dissected into portions that makes technically to work the lens out is easier. Then also because, as you pointed out, pneumodissection, it's all these things. This zonular stress is definitely decreased. That's something you cannot measure, of course. It's just a clinical experience. But this also means that for pseudoexfoliation, post-traumatic eyes, or with or without subluxation, for example, the LENSAR is perfectly set up. Also, if there are capsule considerations, let's say it this way, and that is also if there is by intravitreal injection, for example, a pre-existent capsular rupture, yeah, or YAG vitreolysis, which is done a lot in Europe for floaters. And some colleagues just blast through the posterior capsule and go through it with a needle. And then, of course, it's perfectly to have a perfectly centered capsulotomy in these complex eyes. And we are also using it on a routine base for combined procedures, that is cataract plus retinal surgery, for example, where I also see a lot of advantages. Think about the pressure from gas exposure, for example, or oil, which often displaces the lens, although they have a good macula and good function afterwards. With the peripheral retinal detachment, they're also very good candidates, because even if there is a bleeding and you have no red reflex, the lens is marked and it's tinted to some extent that you can see the lens and don't need a red reflex, yeah? Because if you vitrectomize in these eyes, you have big, shallow anterior back and forth movements and all these things, which is not the case if the vitreous is extracted and the laser is perfect in these situations. And many others, that is small pupils, you can do it. That means the laser is in the OR and you would then insert a Mayugin ring or whatever, iris hooks, that's all published by us and demonstrated the technique. And you can then laser it, and it's a lot of beneficial advantages. It's the indication for pediatric eyes. I can't go into detail, but oh my God, the quality of the cut is so good. You can exactly position and exactly perform the capsulotomy the size you exactly want. You need a little formulation, the formula that the Bochum formula that Tim Schulz and I developed. And for example, Marfan's syndrome, of course, it's where you know how hard it is to perform a capsulorhexis, and with a given capsulotomy, it's perfect. Next, please. And as I mentioned before, also, there is a little bit caution warranted. Of course, not everybody can be treated. So I would ask for, in the very rare cases of posterior polar cataracts, or if the anterior chamber is a little bit shallower, there we have the chance that with the system to individualize and adjust it, which is unique also, because it's not what you get on the table you have to eat. You can then select again, and I'm gonna go into detail later on. And also I would say in intumescent white cataracts, which are not all are under pressure, but if they are under pressure, I would say, okay, a capsulotomy, you should be carefully, because you need a very small capsulotomy. The smallest you have, the faster you are, the better. And of course, if there's silicone oil in the anterior chamber, or if there is a phakic IOL interiorly, like an ICL or an iris fixated lens, where I would say there is no need to do through this lens, because it works as a magnification or aberration, laser aberration. And that means that not every spot is at the same position, what you usually are used to. Next. And I mentioned the individualization, because there had been rumor in articles, etc., and that you have to take what the system offers, but it's not true, because as a user, most of us will know it, but not everybody knows it, that after the scanning has been conducted, you tap the review button. And then you can review the scan, which you can see on the right side. And that means then you can manually adjust the anterior and posterior cornea and lens surface if the automated detection failed. And this can occur in extremely flat anterior chambers. That's I'm talking about flat anterior chambers of 1.8 and smaller. That is extremely flat, where of course every system is challenged. But this system can then guide you through once you go manually through it. And you can see on the right hand the blue triangles, which you relocate and say it's the system exactly where it is. Because to be sure that exactly everything is conducted as you want it, based on an individual anatomic situation. And this will override the limitations to any anterior chamber depth, and provides you then a 3D modeling for the treatment, which I think is an outstanding tool. Next, please. And last, I think, will be next, please. I'm not sure what happened, but what I can say is, yeah, that of course, what I would adjust again, the energy and corneal issues, if there is a cloudiness increase, the energy, and if the pupil comes down and you want to implant, for example, a lentis IOL, which is perfectly to also not only as a perfectly centered into the capsulotomy IOL, but also for negative to decrease negative dysphotopsia, etc., especially for the second eye procedure. Can you go back one slide, please? Then you flap, turn over the flaps anteriorly to the iris, and bring them up the flanges, so to say, of the IOL, which you can see on the right. And then you, with the iris manipulator, you move elevate the iris a little bit up on the flanges, and the lens is then perfectly centered. And there is a restrict nucleus also in the software, where I would say you can shorten the leasing time. You can always reduce the safety zones. That means adjust individually the pupil size, etc. So you can nearly treat everybody. And but you need to know that it's a machine, and once it, like a car, the best is not to rely on the automatization, but if you see something is happening, you take back your foot from the foot pedal, and the system stops immediately, which is always good. And as I said, small pupil is not an issue. And next, please, if you want to dig into this in more detail, so to say, we just have a recent book that's coming, that came out with several hundred pages, with all about femto. What you will want to know, you can read in detail there, including all about the LENSAR system. Next, please.
Burkhard, those are excellent points about using the laser in complex cases, and you made some amazing points about the value of the laser. And a couple of things that I've noticed that you referenced a little bit was one in like in the very shallow chamber and a very dense cataract per se, and you want to use the laser. The machine does have a built-in safety mechanism, so if the anterior capsule is that close to the endothelium, you don't want any laser energy to hit the endothelium. But you as a surgeon, and this is one of the things that I think the LENSAR team is so good at, they want to protect the patient, they want to protect the surgeon, but they also want to empower you. They don't want to kick you off if you feel comfortable doing it. So you can override it if you want, if you feel there is enough room, or you feel the endothelium is very healthy and you really need that capsulotomy of a certain size in the right location. And you can change the parameters, but it will prompt you to warn you. The same thing happens when you have a white intumescent cataract. There's so much light reflection from the shine fluid camera that it's so hyperlucent on the image, it can't see the posterior capsule because it's white, and it can't get through it to image it on any system. So it doesn't want to, treat it and rupture the posterior capsule with a laser. It's intelligently going to say, hey, we can't find the posterior capsule. What do you want to do? So for me, if I know that it's a really dense cataract, like if it was a white cataract and just a soft liquefied cataract, I don't need to do any fragmentation. I just need the capsulotomy, right, which I totally prefer. But sometimes you have those white cataracts, but by looking at them at the slit lamp, you see that orangish, brownish glow in there, and you want to frag it. Maybe it's got previous trauma to the eye. So in those cases, I can assign a depth to the fragmentation patterns, 2 millimeters, 3 millimeters, 4 millimeters, and it measures, at least you can see how big the lens is, and you can say, okay, I want my fragmentation to go down 3 millimeters deep from the anterior capsule, or 4 millimeters if it can't read the posterior capsule. So they've built in and that's only from surgeon feedback, Burkhard. As we, yourself and myself and other surgeons have told LENSAR what they want the system to do, they have augmented the software to allow us to have this type of control, which is wonderful ability to continue to help have this laser be modifiable and customizable for what the surgeon wants to use it for. Well, let's move on to our next section.
And there's one thing, Robert, if you allow me, there's one thing I would like to add to this. If you want to fragment my recommendation would be, my strong recommendation would be that the fragmentation diameter is smaller than the capsulotomy, because the laser is firing from inferior to superiorly. And once you have fired the anterior capsule and the fluid egresses, the back collapses and comes closer to the fragmentation. But if you're choosing the capsulotomy diameter smaller or the same as the capsulotomy, this is not an issue.
Totally right, and there's also going to be some opacification at the edge of the capsulotomy, which won't let that fragmentation energy get through that opacification. So the laser energy is definitely going to be more efficient through clear media, which is the center of the capsule, an hour smaller than the capsulotomy. Great.
Yeah.
Okay, let's move on a little bit more towards how Burkhard and I function in the operating room. And everybody has their unique thing that they do in the operating room, the way their surgery is set up, whether the femtosecond laser is in their room, whether the femtosecond laser is in a separate room. There is no right answer here. All we can do is show you what we do. But on that note, it might be a nice opportunity here to pause and let you know, in the spirit of innovation and the spirit and the mission of this company, and some of you may have heard rumors of this, but I'm here to let you know that what the truth is that there is another machine in development right now. And the goal is to, within 18 to 24 months, I would say is a reasonable window, to have a device that has femtosecond laser and phacoemulsification built into one machine that's a smaller footprint, with one pack, with one tray, that comes ready to go at a great modest price point, to where the patient can come into the operating room, the laser can come out after the patient is prepped and draped, the laser arm can come out, do the treatment, exactly the same things you're seeing on the current generation, the best parts of that, but even quicker with a much more sophisticated camera, multiple cameras, and then retract out of the way quickly. And part of the same apparatus will be a phaco handpiece, an aspiration, and an IV, all together in one unit, and you just go. So this is what surgeons have been asking for. Instead of having all these machines, this is the natural direction. And there's no question in my mind that this company will not only develop the first combined platform, but of course, since it's going to integrate LENSAR's already amazing and most advanced femtosecond platform, it will therefore probably be the best machine on the market on both ends. And the phaco platform that will be built into this device, I promise you, you will not be disappointed, and many of you, especially in Europe, will be very pleased with the technology on the phaco aspect of this too. So it's something to look forward to as we look down the road in continuing to evolve and continuing to advance this space of cataract surgery. So let's talk about my flow for a little bit, or I can't remember if mine or Burkhard's up. Let's pull up the next slide there and see where we are with that. Okay, I operate, hold up for 1 sec there, Lauren. I operate with a fellow. So I have a private clinic, and when I do my consults, we have a very team approach. We work as a team. I always do the most challenging or important parts, and I'm always there for procedures, but I have surgeons that help me. I have a fellow every year. And I have 4 ORs. Now, one of the ORs has no surgical equipment in it except for the LENSAR room, the LENSAR laser. So one surgical room has totally been outfitted just for femtosecond lasers. And the other 3 operating rooms are set up for phaco. So I'm constantly doing a little bit of a rotation moving between all these rooms. Now, sometimes I'll just operate out of 2 rooms, but coming through the door here, you see my fellow. My fellow does almost 100% of the femtosecond lasers once they're trained in the first month or 2 of their year, and then they start to get into the surgical flow with me. So you see up on the screen in the corner, there's a video screen where I'm able to see that's in every room. I can see what's happening in every room, if the patient's being prepped and draped, if the patient's already prepped and draped under the microscope, if my fellow is under the femto, if there's a patient in the femto room, if my fellow has already begun as part of a surgery in one of the cataract cases. This lets everybody communicate and keep a very high volume flow, and we are able, between my fellow and I, to do 10 to 12 cataract surgeries per hour. Usually 8 of those 10 cases are femto, 6 to 8, somewhere in there. So we'll typically do 25 to 30 cataracts in an afternoon between 1 and 5. And if you add in the femtos, it's really like probably more like 60 procedures, 65 procedures, including femto, that are done in that period of time. But you have to have a lot of great staff, obviously, amazing team, amazing surgery coordinators, counselors, check-in process. Let's run the video. This is a little interesting to watch. It's in high speed, but it gives you a sense of how efficient the flow is in what we do. We operate 100% 3D. You see that this is my fellow Brad last year. He goes and moves on. I'm in another room doing a cataract procedure. He's starting a cataract procedure for me right here. Here's me in another room operating a procedure, heads up. Brad finished a case, I finished a case, moved to another room, finishing another surgery here. You see we have intraoperative aberrometry we use on the screen. Brad has finished his femto, so he came and watched me for a second, and I gave him some pearls as he could see what I'm doing. And here again, now I'm watching him operate. So there's a lot of movement, a lot of collaboration as we work together, with him watching me watching him, and basically just continuing to move these patients efficiently through our process. And that's kind of how we do things on a daily basis. We're doing that 3 days a week, 3 afternoons a week, operating like that. It's a lot of fun and very dynamic and quick pace for those people who have seen me do that. And obviously anybody's welcome at any time to come. We're very open to visitors, or anybody who happens to be in Tampa Bay. Please come by and join us in surgery. We always have a lot of fun. So next slide. Okay, so Burkhard, let's take a look at your flow.
Yeah, amazing what your speed. We have to discuss that later on. But first of all, let me discuss and tell you what we are doing. We have 5 ORs, and in 3 ORs we do cataract surgery. In each of these 3 ORs, there is a femtosecond laser. We also do, once we are opening the capsule or the cornea, we do it under sterile conditions because we have to do it. And the LENSAR is in one OR and feeds another OR where there is another system, but we more prefer using the LENSAR over it and moving patients rarely from that place away. Usually the femto laser is in the OR, and the patient remains there, it's lasered, and then intraocular procedure is finished. And so we do surgery on 5 days a week, and that means from 8:30 to 4 o'clock, and sometimes even at the weekend. And what I can say is we are doing, in average, we are doing 8 LCS cases per day, and that translates to a total cataract volume of 3.5 to 4,000 cataract surgeries a year. So here you see how we're doing it on under sterile conditions. So what we cannot do is moving from outside somewhere else, moving the patient to somewhere else. So that's something we don't need in this setup. And next, please. I'm going to show you a video that is, of course, also speeded up. It shows 10 cases on last Monday, on this Monday, with 10 cases conducted in part by a resident and a fellow who was trained, of course, in this. Can you run the video, please? And so in several cases, the patient is already lasered, or I educate the fellow so that there is interaction and discussion what can be improved. Also, you can see the setup here. We have anesthesia team. We have ceiling mounted OR microscopes, the Zeiss microscopes. And then I move to the next OR where there is another system. Here you see the only OR where we don't have ceiling mounted. And so I jump into the procedure. In this case, for example, the lasing has been done. Moving to the next patient. And the team is already ready there, and the coordinator guides me through the program. So someone from the team tells me what is my next case and prepares and looks for it. So what we cannot do in Europe is having a screen like you, Robert, in the US, where the other places are, so to say, super viewed, because you cannot see the working places and the people at the same time with this, which is from a personal point of view not allowed. And so that is a little bit more analog, so to say, but also works very well. And
but you have those big, beautiful windows you get to look at.
Right, that's which shows you all the nice seasons over the year. And by the way, we had per year we have about 250 surgeons from worldwide who visit us, pre-COVID, of course, in mean, who want to see how we manage all these things and how we handle all these things. On the left side, you see Dr. Schnober, who has prepared and is looking, and the patients already is there. Sometimes patients are privately insured. We have a dual system. That means 20% in Western Germany is privately insured, where the insurance company may take over the money, the costs. And we have general insured. That means that there is a basic proportion is paid, but the patient can upgrade and say, for example, I'm going to take a premium IOL or a lasing. Here you see the OR. On the back, you can see the screen. And then I'm sitting at the 12 o'clock position at all times. And depending on the preoperative astigmatism, depending also, of course, if we used arcuate incisions, I'm operating on the steep meridian, and that means 12 o'clock or temporal, oblique or temporal from the side with the right hand or with the left hand for the left eye. And here you see, I always have to introduce myself to the patient before they get any sedation or something like that, because in Germany and most parts of Europe, it's a personal treatment that it's demanded that you do it on your own. You cannot delegate the intraocular part, and the lasing part, as you can see here, the teaching to one of our colleagues, is always under supervision, of course, irrespective if I'm standing aside or if I'm a little bit in the other room or something like that. But we trained more than 30 surgeons so far, and that is one key point also I want to make, that it's important that others learn this technology so they can spread out. It's not good if only the dinosaurs and the big people use the system and sit on the laser, rather than educating the others and spreading out the genes, so to say here. And yeah, as you see here, for example, there is an anesthesia team on the side also. They are taking care of the vital parameters of the patient, and sometimes very rarely we do it under general anesthesia. Most cases it's a topical with only drops procedure. Extremely rare that we're using a retro or peribulbar anesthesia if this is necessary. Okay, you can stop the video here. As you've seen, we're not that fast like you are, because it's a personal procedure. I'm jump in between 3 ORs. That keeps the pace, so to say. But and we did this on Monday without, hurry or something like that, just the normal way how we would do it. And we were doing 10 cases that have been conducted by me in 2 hours and 11 minutes. And there were difficult cases also there, and also education that is in here, which is, I think, very is mandatory for all educational centers, so to say.
Yeah, I think that it shows well that there is no right way to do any of this. It's very individualized, and you don't have to have the laser in a separate room, or if it's in the OR, they both work fine. The greatest commonality that I see is that we have very caring teams around us that are equally caring for the patient and caring for the surgeon, to make sure the surgeon stays in the right frame of mind and stays at a pace that they feel comfortable and not rushed, but not idle. Because I think we all know that we function better when we kind of get on our own personal zone, and we can concentrate and we're not distracted, and we perform better, just like any professional would. And to have the right team around you, is more important than any of this technology. And I can see by your video that you have people that are extremely dedicated to you and your patients in making sure they have an amazing experience and that it flows perfectly for you, which is the hardest thing to accomplish for many of us. So very, very impressive, Burkhard.
Likewise, thank you.
Let's go on to the next slide, please. So, you know, doing the laser cataract surgery in settings like many of you have, no matter where you are in the globe, it's not just about the technology and how to use it, it's about how to integrate it into your practice. And for most people, there is some component of engaging patients and getting their buy-in on not just doing cataract surgery, but also taking advantage of the opportunity that cataract surgery holds in freeing themselves up from glasses and contacts, and helping them understand that cataract surgery is a refractive procedure. It's designed to not only clear their vision, but it's also a potential opportunity to not need glasses or contacts afterwards to see clearly. And we spend a lot of time in our practice, and I know Burkhard does too, because we have a whole spectrum of patients that are have Medicaid, which is basically our less fortunate people in our population, but we take care of them nonetheless, no different than we would anybody else. And our mission in our clinic is to take care of anybody's vision, regardless of their means or walk of life. And so we have packages of great cataract surgery for people that are on a very fixed income, all the way to very advanced refractive types of cataract surgery for people who can afford it and have the means to get themselves out of glasses at the time. So next slide, let's go through that. Burkhard, tell us a little bit about some of the things you do to educate your community and your practice.
Yeah, well, first, of course, will be the patient information seminars, which we offer. We just start now with offering more or less web-based. Of course, press release if we have a new system or a Memorial Day or something like that. We use roll-ups in most of the locations to make patients aware in waiting rooms, etc. Then one very important thing is that we have a refractive counselor, because we have to inform the patients on all different modalities, lens technologies, but also femto laser use, and to stress out what is possible. Of course, patients can say, no, I don't want anything of all these things, and truly rely only on the golden hands of the surgeon. But on the other hand, also it is important, we need to document that we are informed about all these things. And we have an iPad with an app to show more graphically what we are talking about. Then of course we have a flyer, one that is provided, for example, from Telion and LENSAR in different languages. Then we have our own flyer, of course. And on the right side, you can see, for example, the roll-up in the waiting room for the general insured patient. And of course, the homepage and press release, as you can see here, one of the biggest journals in Germany. It's a focus report on our work in Bochum, Germany. And of course, we have a YouTube account. Next, please. And Facebook activities. And Twitter, these things, which is conducted by professional people. With of course, we give the content and provide them the information to share. And here's the homepage, for example. Next, please. And we try to keep it less commercial, but informational. And the YouTube is accepted extremely well. I'm wondering about that because you see the real surgery, which nobody wants to see usually. But because everybody, if you show it on the TV, everybody would switch away if they see a knife moving to the eye, but which of course does not occur in LASIK. And next, please. And so YouTube is also a good tool to just communicate. And we had a lot of watches already. and we are sharing innovative surgery, etc. Whatever can be shared is also in this YouTube channel. I'm not sure what you are doing, Robert.
I mean, it's amazing the similarities, you know. I think that we've both figured out it has to be a multifactorial approach to educating the community and our patients about what we do, and it's too hard to wait till they get in front of you to explain all this. They need to trickle the information in slowly, different medium, website, Twitter or Facebook posts, newspaper advertising, billboards. They need to understand what cataract surgery is, and they need to understand what laser cataract surgery is, and they need to understand, most importantly, the opportunity that cataract surgery holds for them in terms of how good their vision can be uncorrected. One of the things that's worked nicely for us in addition to what you've said, is on the bottom right of your screen there. This is pre-COVID, of course. We have a large 3D screen, and we will do a live cataract surgery seminar where there's a lot of people have anxiety about cataract surgery, and we advertise in the newspaper to come in on a certain day, maybe once a month, where patients come in and they get a snack and a drink, and they get a brief lecture about cataract surgery with some simple slides describing what it is, all designed to ease their anxiety and fear about cataract surgery. And then I'll go upstairs and I'll do a live surgery that's fed via the signal in 3D. They'll put on 3D glasses and they'll watch it. And then I'll come down with the patient, and they get to see that the patient can get right up and get back to normal and have a drink and a snack. And you know, usually they've already had their other eye done a week prior, and they get to ask questions and answers. It's a nice event. So we keep trying to educate. Next slide. I'm a very, I would say, you know, very lucky guy, because I have an amazing team around me, and my team, whether it's the front office, front desk, or the workup techs, they are all educated about how to communicate with patients. So they're already talking to the patients about the laser. They're talking about astigmatism correction. They're talking about special lenses that the doctor may offer or may suggest as a good lens for them to help them have the best vision possible. But ultimately, it comes down to a surgeon recommendation. And I've heard this over and over, especially from industry people, that it doesn't matter how many brochures you have, how many pretty pictures you have, how good your website is. If you can't look a patient in the eye and say to them, listen, you have a cataract, you have astigmatism, your eye is not shaped round enough to really focus light well, and if you want to see your best, I recommend that you get this lens, or you take advantage of this opportunity to correct your astigmatism with the laser, and I think this would give you the best possible vision. And when the surgeon makes a recommendation and it comes from the heart and has done the right preoperative diagnostics like OCT and topography, the surgeon can make the right decision for that patient in the exam room and makes that recommendation, and then the surgery counselor then follows up with that recommendation. That's typically what works the best to engage patients in their vision and get them to make even though it's substantial financial commitment, gets them engaged and gets them to realize the value of that. Next slide.
Robert, what is the secret behind the conversion rate of 70%, which is really high? I'm not at 70% at all, although the Germans are so technically affine and like technology. You know, once you talk about technology, you could per hours talk about cars like the BMW, Mercedes, Porsche, etc., etc. But you are in the US, and is it the reason that the Florida is so rich, or 70% is an impressive number?
You know, our area of Tampa Bay is not Coconut Grove in Miami. It's not Sarasota, Florida. It's not New York City or some wealthy part of Beverly Hills. It's a very working class part of Florida. And what our numbers tell me is that 30% to 40% of our patients literally don't have the means to do it. They're on a fixed income. They literally do not have the money to invest in their vision. They don't have any disposable income. The other 60 to 70%, they are given enough of an understanding that if they can afford it, it would be silly for them not to improve their vision at the same time of cataract surgery and fix all the problems of the eye. Fix presbyopia, that's a disease. Fix astigmatism, that's a disease. Fix the cataract, that's a disease. So we spend a lot of time educating that this is just isn't cataract surgery. We're going to fix other diseases at the same time. We fix glaucoma too. We're starting to do more and more eye stents and hydrous implants for people that are on multiple meds. So we want to do as much as we can to help the patient if they can afford it at the time. And we talk about technology a lot, but my patients don't know what a LENSAR laser is. They don't know what intraoperative aberrometry is. Sometimes with more educated engineers, we'll get into it. I might say I have a special machine that I can measure your eye after the lens is out. I might say I have a laser that I use to correct astigmatism that helps me be more precise. But like I said, I think it's really, it's about the vision. It's about what the outcome is going to be for the patient, and in combination with technology.
And what are you charging for the laser only, or are you giving them packages or something like that?
Yeah. Go to the I'll go through our packages. I think they're similar to some of the things you would do as well. But the packages, basically, we want to offer something in the price range that everybody can afford and have access to technology. So Lauren, bring up those packages. But basically, we have kind of our premium, most advanced technology and most precise vision, from what I truly feel is the most precise thing I could do, which is a light adjustable lens with femtosecond laser. I can't really think of anything more precise than a lens that I can adjust postoperatively, coupled with the precision of a laser. Under that, we have presbyopia correcting option with a presbyopia correcting trifocal. We're using a lot of the PanOptix lens right now. We're having great success with that. I also use some of the TMF low-high, the ZK-BOO and ZL-BOO in combination. So that's a little bit less money. And then we have kind of our most common thing, which is people that, most people don't want the cheapest thing. They don't want the most expensive. They kind of go in the middle. And that's our custom vision package, which typically is both eyes targeted for distance vision with a good monofocal IOL or a toric IOL, or arcuate excisions with the laser, intraoperative aberrometry. Sometimes we'll have to do LASIK or PRK postoperatively, but that package is kind of a guarantee, like, hey, you're going to see great in the distance. All you're going to need is the reading glasses and the computer glasses, and if you want, you can buy those from the drugstore or from the supermarket, or order them online from Amazon. But a lot of people are like, hey, I would love just to be able to see great in the distance and just have to wear cheap reading glasses. And a lot of people just kind of drift towards that. And then we have then there's even patients that want laser cataract surgery but can't afford that. So we do an arcuate incision package, like a LRI package with the laser. We don't put LASIK in that. We don't use Aura, but we do use the laser. We tell them their glasses would be much thinner than they're used to. We don't want to make any guarantees, but at least that gives them some access to femtosecond laser technology, so they feel like they're getting some of the best technology out there, but the promises are not as high on glasses freedom. And then we have, roughly 25 or 30% of our patients, they basically fall into a demographic where they really can't afford any of that, and we do, good old-fashioned cataract surgery. Of course they do well. We don't want them to feel like they're getting a second-rate procedure. We want to give them confidence that they're going to see good, and of course they do great. But their expectations are that they're going to wear glasses all the time, most likely after cataract surgery. How about you?
Well, a little bit different. I fully agree with you on the light adjustable lens technology. We have been using it for more than 12 years now, and also with in conjunction with the femtosecond laser, I think it's the best solution currently available. But that translates to costs of about more than 5,000 euro per eye, and that is a lot for that. Not everybody can afford that. But of course, those who can afford, and we have done that in 700 eyes, really are functioning extremely well and very happy. They can see the golf ball exactly where they want it to be, and etc. We cannot sell packages because in Germany and in most parts of Europe, everything you do is exactly predetermined in the pricing. That means if you measure IOP, you have a clearly amount of money per cent, so to say, what you can charge. And I cannot bundle all these things and say, okay, for 500 bucks, you get the EDOF lens additionally or something like that. That's not allowed, and the patients down the road will have to have a bill where everything precisely is written, what costs this and that, etc. And because we have an insurance company behind that will check everything and maybe cut, and then there will be a discussion, something like that. That means packages in terms of bundling, etc., is for us not a good way to do. But it also works similar, like you described. It's what the patient wants, and so if they want a multifocal lens, they get the multifocal lens, and then they can decide whether they want a femto laser or not, or both. And the private patients, privately insured patients, as I said, 20% in our population in this middle western area, is the conversion rate there is definitely, I would say, at 60 to 70% minimum. But in the general insured patient, it's a little bit down, less. So what I think is impossible in Germany that we sell it or advertise it or something like that, because the people here are very critical. Yeah, once that you say, oh, super duper, etc., then they will be thinking you are making jokes, but you are not someone we can rely on. And you have to inform, as I said, on all technologies, which is a burden to some extent, because that means they have to understand. And once it comes to the court or something like that, you have to document it. What I recommend personally is, in specific cases where I'm fully convinced, based on all what I know from the decades I'm working already, that the LCS in these eyes is by far superior. So then it's recommended to the patient, because otherwise you get closely that you may drag out money out of a patient who has his only eye or something like that. And that is critical in Germany, because we have a lot of colleagues who are not using a laser. And of course, for them, we are a target, let's say it this way. And so we need to be at least careful in communication and information. Its reimbursement also by the private insurance companies is currently under decision in courts with expertise, etc., etc., and it's not decided yet. That means it's a very critical situation for us for the whole technology currently. That means if this goes in favor of the private insurances which don't want to pay at all, then it may be the end of LCS in Europe. And that is currently a very critical situation, and all communities and societies are trying hard to work on that. But definitely, the LCS brings us to a new level of patient care and communication, no doubt.
Yeah, do you feel like because some surgeons don't use it and you have to gain their trust, it seems like in in the United States, most of the time, by the time the surgeons get in front of a surgeon, I mean, the patients get in front of a surgeon, they've talked to friends, they've talked to their primary medical doctor, and they've heard that, that Professor Dick is the man for cataract surgery. So you would think that these patients would just accept what you have to say, like, I think this is what you should do, and they would just accept your expertise because they've been referred to you and they trust you. Is that not the culture? You feel like people have to understand it a lot more, and they're skeptical in general? Or they're
skeptical in general. They're skeptical in general, irrespective if you are a super duper expert or not. Moreover, what is important to know is the fact that our referring doctors sometimes specifically ask that the laser patient is not lasered. And then you detect, okay, this patient has a corneal endothelial issue, and you come really in problems. What you do? And I had these cases, interestingly, and one of my referring doctors called me, said, okay, you will not do lasering on this patient but I did it. And the good thing is it worked so well that the patient did not need a corneal keratoplasty, although the other eye had already after a standard procedure. So, and now this referring doctor, and that is the work we have to do also here, that these referring doctors are convinced that this is a good option. And once it is a good option and they accept it, they are sending you these patients specifically asking for femto already. So the patients are already primed. There's no need to discussion. They feel informed already.
Yeah, I think that'll probably happen more and more. And with the Generation 2 machine that will come out, where phaco and femto is built in, and you'll have the option to use the femto if you want, it'll just be right there in the operating room. I mean, I will probably move to a flow like you have, where obviously the laser will be right there. And it won't be much of a question anymore. It's a tool that you use to make a better capsulotomy that you could ever make by hand. It's a marking device for torics that you formerly had to do with a less sophisticated piece of technology. It's a nuclear disassembly tool that you use because it's better than using ultrasound alone. And I think that it's our job just to inform our colleagues and help industry evolve this technology. So it is not a question of whether you use it. Like, you don't question whether you use phaco. You don't tell the patient, well, I could do it with ultrasound, or I could do it and I could just take the lens out whole and put a few stitches in, and have to go through this whole education process with the patient on what they think is better. Because I guarantee somewhere in Germany, there's somebody still doing extra caps, because I know 30 minutes down the road here, there's somebody doing extra caps. So it's like you have this spectrum of evolving of the technology, and whatever new is always going to go through this process of being accepted as whether it really is the standard of care or not. And that's just part of what happens in the process. So I think we're just going to have to continue to navigate those waters and continue to show our colleagues that this technology is going to provide better outcomes for their patients. I think this has been a wonderful session. We're running short on time. I'd like to thank Teleon and LENSAR for an amazing job of putting this together, for Lauren Kanner at Square One, and Tricia Ekema at LENSAR for her amazing organization skills of putting together a great PowerPoint across the big pond here, and to Heidi Merriman for her leadership there as well. Any comments from any of you all? Burkhard, do you want to say anything first? Any closing comments?
Yeah, I would like to thank, of course, again, Nick Curtis, because he allows us to use this technology, but also to share information and education, which is so important. I'm not aware of any other company that's currently offering webinars or so in this time. And also, of course, Markus Scheidt from Teleon, who is a good friend of mine, but also runs an extremely well team. And all the team behind are very clever, are keen, take care, and are keen, informed. And so it's for me, it was very vivid seminar here. I really loved it, the interaction with you. I really enjoyed it. Time flew, because if I look at the watch, we are done. It's unbelievable.
Amazing work. I really enjoyed, as usual, spending time with you. I look forward to seeing you in person again, hopefully before too long.
And all the other participants.
Yes. Any closing comments from anyone on the Teleon or LENSAR team? Heidi?
Yes. Hi, Rob. I wanted to just share with the folks that are actually on the webinar that we will be having a sneak peek virtual event of the new device that's coming out that Rob spoke about. It'll be the first combined platform of femto phaco. So for those folks that are interested, please go ahead and let us know in the chat box. But all of those that are registered on the webinar and we've got their email address, you'll be invited and informed when that will happen. And I want to take the time to just thank both of you for sharing your insight on the LENSAR laser and how to successfully integrate this into your practice. We greatly appreciate your time.
Thank you.
Thank you also to all participants, and thank you, Robert. It was a pleasure and honor to be here.
Same. I hope everybody stays safe and healthy, and keep making patients see great and then have fun. Take care, everyone.
Take care. Bye-bye.